We're going to our guest speaker today, Dr. Bender. So I've known Matt for quite some time. He was a co-resident of mine at Johns Hopkins. When I was a chief, he was my PGY3, or the most senior junior resident. He was quite efficient. He multitasked very well. I remember him on call. He'd show up in the morning to run the list. He'd be on his bike, on one of those bike trainers training for a triathlon. During his residency, he also had several injuries related to his biking, but still kept going. And now he's currently a professor at the University of Rochester. You can see here are his education positions and titles. He did his residency at Johns Hopkins, as well as an infold to endovascular fellowship. He's now currently an assistant professor at the University of Rochester, primarily specializing in cerebral vascular disease. You can see here are his publications. He has several publications with a very high impact factor for an assistant professor. I'm sure he's on the cusp of becoming an associate professor with an H index of 19. So welcome, Matt.
And the only thing that I can add, I believe, so Matt was already, I think you were a PGY4 by the time I was leaving Hopkins in 2016. And what I do remember interacting with Matt, exactly what Kai said, in a tremendous, I mean, I remember you coming to, do your rounds and working with the team after you sustained a major injury, actually, and kept working through this injury with casts. And I don't remember how many things you had on your body, but it was amazing to see your dedication, your determination, but also your organization and your ability to work with people and your productivity during your years of residency. I think that we were very blessed to have you, to learn from you, and also to match you, obviously, when you were going through the match at Johns Hopkins. So it was quite a privilege, and to see you grow and to be there in Rochester now with great colleagues, especially, of course, working with Ed Bates, who is also dear to me for many, many years at the University of Rochester. So thank you very much, Matt, for being here with us. We're just very lucky to have you and looking forward to your remarks.
Yeah, he literally had a chest tube on studying for his boards, and we had a round on him in the morning just to make sure he was okay.
Yeah, I fortunately I haven't suffered any injuries like that in a while. My wife is pleased about that. But thank you, Kai, for the generous introduction, and thank you, Dr. Q, for welcoming me to this forum. It's a privilege to be able to talk with you guys about. And actually, I'm astounded by the volume of activity that there is based at your institution and its reach, into an international setting. So, it's awesome for me to be able to join you for Grand Rounds and be inspired by all the activity that you guys have going on. So I just wanted to say thank you for that. I'm going to talk today about, my talk is titled Proteomic Insights from Cerebral Arterial Thrombus, Implications for Acute Ischemic Stroke Etiology and Treatment. I'll admit, my background is as a philosophy major during undergrad, and a management consultant for a couple of years before I started residency. So I've never wielded a pipette all that well, and I'm an opportunist with respect to research. I came to University of Rochester with an interest in platelet aggregation because I had a lot of exposure to flow diversion during my fellowship and residency and the antiplatelet therapy that it required. But I shifted my interest when we conceived a new way of studying the novel biospecimen, which is cerebral arterial thrombus. And the talk today is really, we let the data speak for itself, and I want to share that with you. Figure out how to work my screen. I have no disclosures. There's too many acronyms even to expect an endovascular neurosurgeon to keep track of. I think you're all familiar with the massive increase in endovascular thrombectomy procedures being done over the past 10 years. And that's because of a series of randomized controlled trials showing its benefit over medical therapy, beginning in 2015 with the early window trials, 2017, the late window trials, DAWN, Diffuse 3, last year with the posterior circulation trials, and just in January of this year at the International Stroke Conference, the large core trials, SELECT 2 and Angel Aspect, showing a benefit to mechanical thrombectomy in patients who already have significant stroke burden. And there's more to come. distal and median vessel occlusions, patients with a low NIH score. But despite its benefit, mechanical thrombectomy is not a panacea and shouldn't diminish our search for other new stroke therapies. And the principal reasons that mechanical thrombectomy is an imperfect treatment are as follows. Number one, ineligible patients. This data is from the University of West Virginia, accumulated over 3 years, 1,400 patients with acute ischemic stroke and intracranial vascular imaging. They observed any intracranial occlusion in 21% and an LVO in just 11%. So accessible intracranial occlusions are going to be a small minority of patients with acute ischemic stroke. The second reason why mechanical thrombectomy is an imperfect treatment is recanalization failure. This is a publication from the Medical University of South Carolina, one of the stroke meccas, that was published in the Journal of Neurosurgery in January of this year, which showed a 12% rate of incomplete reperfusion of TICI2B or worse. And what they also showed actually is that recanalization rates are declining over time. They went from 94% recanalization during the early period to 86% in the more recent years, likely because of indication expansion. Distal vessels and late window strokes are harder to open up. And this is what should be happening, actually, because I think we're all familiar that procedural duration, procedural complexity, the number of passes are all associated with worse outcomes and increased risk of hemorrhage. So as we treat patients with milder symptoms and larger core infarcts, there's more potential to harm and we need to stop sooner. In the Hermes registry, which represented data from 5 early window RCTs published in 2018, the recanalization rate of TICI2B or better was actually just 71%. Reason number 3 why mechanical thrombectomy is imperfect, because we have a number of patients who have good baseline function, who get early treatment, who have a quick and uncomplicated procedure with a great recanalization outcome, but don't experience an excellent clinical outcome. This is the concept of futile reperfusion, which describes patients who don't achieve functional independence, that is an MRS of less than or equal to 2, in spite of all of these favorable indicators. And that accounts for about 50% of the well-selected patients that we treat with mechanical thrombectomy. I think this one's going to be particularly relevant in this forum, given the diversity of backgrounds that people represent. Mechanical thrombectomy is imperfect because it's a resource-intensive procedure and access is limited, except in urban centers of high-income countries. This is a publication from really the past several weeks by the MT 2020 consortium, led by Dilip Yavagal at Miami, which reported the results of a survey of 75 countries in an effort to assess capacity and access to mechanical thrombectomy. And what they found was that access in high-income countries was 20% and less than 1% in low-income countries. That gap is going to take a really long time to bridge. Twitter is crowded with images of fellows at the controls of Corindus endovascular robots. That's one way to resolve the surgeon component of a staffing crisis. But there's a whole lot of other people, facilities, and capital that are involved in opening an occluded intracranial vessel. All of which is to say that while we're doing more and more mechanical thrombectomy, additional, more scalable therapies for stroke will continue to be sorely needed. The good news is that we've been furnished through mechanical thrombectomy with a biospecimen that can teach us about all types of acute ischemic stroke, not just large vessel occlusions. And that's retrieved embolic material, or cerebral arterial thrombus, whatever you want to call it. And really, we had no access to this biospecimen 10 to 15 years ago. It's very different than other parts of neurosurgery. Neurosurgeons, neurointerventionists, as the people opening the vessel at 10 p.m. on a Saturday night, have privileged access to this biospecimen, which was initially thrown out at the end of these procedures, but now is increasingly being studied. The vast majority of the studies on stroke thrombus are simple histopathology, and we've learned a lot from them about clot constituents and clot organization. One of the themes is regionalization. There's large swaths of red blood cells with thin fibrin strands in those regions. And then there's more complex regions consisting of platelets with thick fibrin strands and von Willebrand factor. I think one of the things you can take away from these slides is that slice heterogeneity is an issue. What you see on histopathology depends on where you look, and histopathology is not comprehensive. Histopathology has also identified some unexpected clot components. In particular, as revealed by these Fulgens reaction stains, it's shown the presence of extracellular DNA, which is the hazy pink that predominates in the platelet-rich regions and is absent in the red blood cell regions. Most of this extracellular DNA comes from neutrophils, which are then called neutrophil extracellular traps. These are some immunofluorescent images, with each line representing a different area, showing neutrophils extruding genetic material. You can see citrullonated histone 3, which is a part of DNA, in green, the DNA itself in blue, and the CD66B, the red marker, in white blood cells. What you can see on these initial slides is that the genetic material is all contained within the cells, and then when the process of mitosis occurs, you can see that it's extruded from the cells and exists on the outside. We'll revisit these later. I first want to talk about some of the insights generated by histopathological study of cerebral arterial thrombus. The point of studying thrombus is to improve our ability to either diagnose or treat stroke. So one of the insights that histopathology generated came from the early part of last decade and has been redemonstrated many times since then, that a hyperdense MCA, as you can see here, represents a clot with a higher content of red blood cells. You can see that statistically significant association between red blood cell content and attenuation of the thrombus. We've also recognized an inverse relationship between the proportion of red blood cells and procedure length. RBC dominant thrombi are easier to remove, while fibrin dominant thrombus can be recalcitrant. There is, however, no threshold that identifies a clot as either fibrin or RBC dominant. It's a difference of degree, I would argue, not type, and one that's strongly influenced by thrombus age. Attempts to determine stroke etiology or causation using histopathology have yielded contradictory results. On the left-hand side of the page, you can see the results of a German study published in the journal Stroke in 2016, suggesting that a lower red blood cell content is present in strokes that are of cardioembolic etiology. On the right-hand side, you can see a Korean study published in AJNR the year beforehand, showing the exact opposite, that cardioembolic strokes have a higher RBC content. The indefatigable Walid Brzezinski secured NIH funding and led an effort to gather embolic material from numerous institutions, resulting in the so-called STRIP registry. Between 2017 and 2019, they collected embolic material from more than 1,300 patients and ultimately observed that there's a higher red blood cell content in patients who have a large artery atherosclerosis etiology of stroke as compared with cardioembolic etiologies. They also saw that dissection had the highest red blood cell content, while hypercoagulable patients had the lowest. But what jumps out at me when I look at these charts is their overall similarity. And I think that what we're talking about here in red blood cell and fibrin content is a difference of degree and not type. So we conceived of a new way of studying cerebral arterial thrombus to overcome some of the limitations of histopathology, which are principally its specificity. You have to know what you're looking for, and it's difficult to find something new. And then the issue of slice heterogeneity, which will never yield a total abundance. Instead, we propose to use mass spectrometry, which can be used to determine the identity of all of the proteins present in a sample and their relative abundance. It does this by exposing the sample to an electron beam, which creates ions that are then deflected by a magnet based on their charge to mass ratio to a degree that tells you their identity. Obviously, it's processing intensive. We don't trust a philosophy major to do these, and instead are outsourcing them to a mass spec core that we have here at the University of Rochester. The data I'll present today are from our first 24 specimens, which we take and immediately store in -80 and then batch for analysis. The output identified nearly 1,800 proteins in the specimens. And what I will share with you are the results of 3 different analytic techniques. Number 1, individual protein enrichment, depicted on volcano plots. Number 2, gene set enrichment analysis. And number 3, pathway analysis through gene ontology. We aren't the very first to use mass spectrometry to investigate retrieved cerebral arterial thrombus. But when we started, there were just 3 studies. There are 5 now, which were summarized in this review from earlier this year. The results depicted here are typical of the existing literature on stroke thrombus proteomics. What is typically reported is a list of enriched proteins with long names of unclear significance. There has been an analysis that's done based on stroke etiology, and finally functional analysis. The outline here is not mine, but was rather in the paper. And the functional analysis tends to be unintuitive and lacking in good statistical tests. The ultimate conclusion of these papers tends to be, this study is good proof of concept that proteomic analysis can be done, but without any significant insights into stroke etiology or treatment. Certainly, proteomic analysis of stroke thrombus has not yielded a single biomarker identifying the cause of stroke or a therapeutic target for a particular patient subgroup. These authors, trying to make mass spec practical, sought to identify a trio of proteins that could reproduce the post hoc clinical assignment of stroke etiology. And they found that with this particular trio of coagulation factor 13, eukaryotic translation initiation factor 2, subunit 3, and the other one listed here, they could reproduce that clinical assignment with 88% accuracy. But that's a whole lot of work to do a subpar job. Stroke etiology is both a blessing and a curse. It's useful because it influences secondary prevention, because it helps us to answer the fundamental decision of whether to treat a patient who's had a prior stroke with anticoagulation or antiplatelet therapy. I know I'm oversimplifying that for the vascular neurologists. But stroke etiology is also a curse because often it can't be determined, or else it takes a long time. This JAMA Neurology article from 2017, depending on the classification system, showed that etiology was undetermined 30 to 50% of the time. So we decided not to begin by analyzing our data based on stroke etiology. Instead, we proposed to look at the single most prevalent risk factor for large vessel occlusion, which is atrial fibrillation. The association between atrial fibrillation and stroke is long established, dating back to some Framingham data published in 1978, which showed a 5-fold increased risk of acute ischemic stroke in patients with atrial fibrillation. But the mechanism remains poorly understood. It's sometimes oversimplified as dysrhythmia leads to stasis, leads to embolization, but that's not how it really works. So as I mentioned earlier, I'm going to present 3 different analyses of our data, and I'll briefly orient you to each of them, beginning with these volcano plots, which we used to evaluate the enrichment of particular proteins that were associated with known thrombus components. The vertical axis on these volcano plots is a significance threshold. Anything above the dotted line is a p-value of less than 0.05. And the horizontal axis is for enrichment. So those vertical dotted lines indicate to the right of this line something that's twofold enriched, to the left of this line something that's 50% depleted. The right upper quadrant up here is going to be the proteins that are significantly enriched in atrial fibrillation. In total, we identified almost 1,800 proteins. 166 of them were differentially enriched based on a patient's atrial fibrillation status. As I sequence through a few of these volcano plots with tags for proteins that are associated with particular clot components, you'll see that the blue dots are highlighted or that the proteins are highlighted in blue for their affiliation with red blood cells or complement. And we could come up with an association for a little bit more than half of the enriched proteins, so 93 out of 166. So let me cycle through some of these charts. Here's the red blood cell proteins. If you look at the red blood cell proteins, they are all within, none of them are enriched or depleted, and certainly none of them achieve significance. So red blood cells, 0 out of 14 of the red blood cell associated proteins were differential for atrial fibrillation status. Complement associated proteins, 0 out of 19 were significantly enriched or depleted. Proteins associated with the clotting cascade, 0 out of 12 were significantly enriched or depleted. Platelets, my original interest, 1 out of 11 appeared in that upper right quadrant. Totally different story for neutrophil associated proteins. 8 out of the 15 appeared in the right upper quadrant, and the others were trending in that direction. Histone proteins, 4 out of 18 appeared in the right upper quadrant, with some others trending in that direction. These are very, very low abundance proteins that, based on our sample size, were very difficult to statistically measure. Sorry for a different day, but 5 out of 5 eosinophil proteins were significantly enriched in atrial fibrillation patients. So our second technique for analyzing our data is called gene set enrichment analysis. And basically the way it works is by comparing your data with existing gene data sets. There are hallmark sort of traditional references, of which MSIG-DB is one, and you use these for some sort of generic affiliations, generic tests. And what we did was we first looked for enrichment of leukocyte-associated proteins, which we found to be the case. The same with myeloid cell types as opposed to lymphoid cell types. And then we looked for enrichment of proteins or genes associated with platelets, fibrin, and red blood cells, and found no enrichment of any of those proteins. Given the histologic demonstration of NETs in stroke thrombus, which I alluded to earlier, and the enrichment of neutrophils and histones found on the volcano plots, the next thing we did was find data sets for NET proteins and used those for comparison. There are 3 published data sets of NET proteins, which were generated through ex vivo stimulation of pure neutrophils. And I'll present those results next. I want to orient you to the output of GSEA results. The chart on the right-hand side of the page is what they typically look like. The proteins in your specimen are ranked in terms of their abundance from the most abundant on the left to the least abundant on the right. That's why you see almost 1,800 of them here. And then the black lines indicate a point of concordance between your data set and the reference data set you're testing for. The output is an enrichment score, which is this green line, and it deflects vertically whenever there's a match between the condition you're looking at and the hallmark data. So a high peak is good, choppiness, and a valley is bad. The second statistical measure for GSEA is a false detection rate, which basically assesses the reliability of your results using multiple hypothesis testing. And the output is a fraction, which represents the proportion of falsely significant results over the total number of significant results. So the lower your false detection rate is, the better. Here's the output from comparison of our data set with the 3 existing proteomes for neutrophil extracellular traps. And the output was an enrichment score of 1.94, 1.88, and 1.61. Anything above 1.5 is very good. The false detection rate, anything less than 0.25 is good. Anything less than 0.05 is excellent. You can see the false detection rate here, 0.035, 0.035, 0.172. So there was significant concordance between our data for enriched proteins and all of the existing data sets, all 3 of the existing data sets for neutrophil extracellular traps. The third analytic technique that we use and that I want to share with you is gene ontology. And the way gene ontology works is that there's a rigorously maintained, universally available encyclopedia of individual genes that are tagged for their function, for their location, and for their associated cellular processes based on the sum of academic literature. And what we were looking at with our analysis today was the cellular that I'm presenting today was the cellular processes of the proteins that were enriched in our atrial fibrillation specimens. The output of gene ontology is a directed acyclic graph that looks like this, and it displays all of the cellular processes tagged by all of the proteins represented in our sample. The shading indicates the processes that are enriched in atrial fibrillation proteins over the background of all of the proteins that were represented in our sample. The arrows point to subfamilies and are preceded by superfamilies. So as you proceed from the top, which is the most superficial classification, to the bottom, you get more and more specific. And then they're shaded for significance. So obviously you want to focus on the shaded portion of the graph. And if you look at the shaded portion of the graph, the most specific functions were neutrophil activation involved in immune response, and neutrophil degranulation. So to this point, I think, as others have said, we've demonstrated the feasibility of acute ischemic stroke thrombus proteomics. But beyond that, we've shown that neutrophil activation is critical to the pathophysiology of acute ischemic stroke in atrial fibrillation by making really three points with our data. Number one, neutrophil and histone proteins are enriched in the AFib positive emboli, that there's concordance with published net proteomes, and that there's functional convergence on neutrophil activation and degranulation. The question is, how does this fit in with our overall understanding of pathophysiology of the pathophysiology of acute ischemic stroke and atrial fibrillation? And there is some precedent. This is an observational study of patients with acute ischemic stroke who had plasma samples. And what they found was that plasma net markers, cell-free DNA, citrullonated histone 3 and nucleosomes were elevated statistically significantly among patients with atrial fibrillation who had a stroke. They were also elevated among those patients whose etiology was ultimately attributed to cardioembolic stroke. Here's another way of looking at the data. This is a prospective cohort study from Poland of atrial fibrillation patients that don't have a history of stroke. So they're enrolled at a point where they don't have strokes. And they sent plasma, looking at plasma markers, including the same markers of neutrophil extracellular traps, citrullonated histone 3, neutrophil myeloperoxidase, protein arginine deaminase type 4. And they looked for incident stroke. And you can see in the patients that subsequently had a stroke, there were significantly elevated levels of all of these plasma net markers. A different way of looking at this data is Kaplan-Meier survival charts that show that baseline plasma net markers above a threshold value predict incident stroke for H3-CIT, for myeloperoxidase, it's the dark line here, and for PAD4. A third piece of evidence supporting the pathophysiologic role of NETs in atrial fibrillation comes from a completely different angle. This is actually from the cardiac literature, from patients undergoing an interventional procedure who had left atrial tissue sampling, which was then sent for proteomic analysis. They performed pathway analysis similar to the gene ontology. That was the third piece of data that I presented. And it again highlights neutrophil degranulation as the most overrepresented process, biological process, in atrial fibrillation when the specimens are taken from the left atrium. I'm going to revert back to the stroke literature here and cite some histopathological studies that show that NETs are not simple, innocent bystanders in LVO. They're not just a marker of stroke etiology and a guide for secondary prevention, but instead, they've shown a direct relationship between net markers in the thrombus, here neutrophil elastase, and procedural complexity as measured by time from groin puncture to recanalization and the number of passes. There are preliminary studies suggesting that neutrophil extracellular traps are a therapeutic target. These are two different ex vivo studies of undifferentiated all-comers thrombus that was subjected to various lytic agents and then weighed at different intervals after exposing it to the lytic agents. With undifferentiated thrombus, you get more lysis when TPA, that is thrombin lysis, is combined with DNase, which accomplishes net lysis. So here's the TPA line, and here's the DNase line. More lysis of the clot when you have that synergistic combination of TPA and DNase. This is some preliminary data of our own. We conducted similar experiments using TPA, which targets thrombin, DNase, which targets nets, and ADAM-TS13, which is an enzyme that breaks down von Willebrand factor, and we observed a synergism between the DNase and the TPA that was not significantly enhanced by the addition of ADAM-TS13. And here's where we bring together the lysis experiments and the proteomic analysis that we've done. So let me orient you to these charts. There's Spearman correlations between continuous variables. The x-axis is the percent weight after lysis. So 100% here means that the weight is unchanged after lysis. And the y-axis is the abundance of a particular protein. What I'm showing you are the abundances of specific histones. I apologize that we haven't yet found a way of summarizing this data. Instead, you're seeing 6 different histones here. But what these charts collectively show is that the more histone proteins you have, that is, the more DNA, the more nets that are in a thrombus specimen, the more residual volume of that thrombus there is after lysis with TPA only. When you combine TPA with ADAMTS13 targeting von Willebrand factor, it remains true that the more DNA material, the more nets you have, the more residual thrombus there is after the lysis phase. But when you add DNase, that relationship completely reverses. And you see that the more histones there are, the better clot lysis you get with TPA plus DNase. The more histones, the more nets, the less residual volume you have after lysis. And the same is true when you combine TPA with ADAMTS13 and DNase. The more histones, the less residual volume. We'll come to a bit of an abrupt end here, but I think we've already shown the feasibility of proteomic analysis of stroke thrombi. The first half of the talk, I sought to show the relationship between the sort of integral role of neutrophil activation in stroke pathophysiology and atrial fibrillation. And then at the last segment, I wanted to show that these nets represent a therapeutic target for stroke generally, but more specifically for patients who have atrial fibrillation. There's lots of future directions here. There are alternative netlytic agents that can be explored, including C-lamidine, which inhibits the synthesis of nets rather than breaking them down, and neonatal NNIF, which is being studied at the University of Utah. The methodology that we used to compare patients with atrial fibrillation to those without can be replicated for less prevalent stroke risk factors. So patients who have atherosclerotic stroke, patients who have stroke with malignancy. And then we can also look at some imaging correlates of proteomic observations and look for, and this is another thing we're doing right now, looking to see if the patient's imaging on presentation can in any way be indicative of the protein composition of their embolic material as a way of, triaging the patients when they arrive in the emergency department. There's lots of different directions that we can take this research. I want to credit the students and residents who've collaborated in this research, beginning with Sajal Akapeti, who's a medical student who's taking a year out to do research in my lab, Reddy Ramani, one of our chief residents, Derek Schartz, a radiology resident here who's interested in interventional training, and Kevin Welly, who directs the mass spec core, as well as these other people.
Great. That's a great talk, Matt. Like you said, I didn't realize you did a lot of basic science research, which is good. Rob, Chris. Robbie, get your hand up.
Yeah, so thank you, Matt. Great talk, a great topic. I'm one of the old guys who witnessed all the changes with the stroke care. This is really exciting to see. Let's fast forward 5 to 10 years. How do you see the clinical application of this? That's question number one. And question number two, with the new studies about thrombectomy, even for infarcted brain, which, we still know that there's an infarct, but now if you open the vessel, those people do better. What do you see the next for stroke care?
Thanks, Robbie. I enjoyed reading about your research yesterday as I was learning about the department and Chris and some of your colleagues in interventional radiology. So I appreciate your thoughtful questions. I think your first one was, in 5 to 10 years, how do I envision something like this being incorporated into the treatment paradigm for acute ischemic stroke? And I think that we're already using some adjuncts for challenging embolectomies. Occasionally we're administering TPA. So I think probably the first thing that I would consider doing would be using a small amount of some of these netlytic agents intraoperatively for recalcitrant thrombus, because you can minimize some of the systemic toxicity by administering them locally, and then you can eventually broaden it. It's relevant, whether, the approach that the netlytic agent takes, whether it's trying to break down existing nets or inhibit their formation. So some of the alternatives like this C-L-amidine could eventually be used as prophylaxis for patients who are at incredibly high risk of stroke. Some of these atrial fibrillation patients who are a ticking time bomb waiting for the stroke to happen. I think that's the most promising thing, and that would help to address some of the limitations in terms of the infrastructure needed for intervention that I alluded to at the beginning part of the talk, as well as the fact that a lot of stroke patients just are never going to be candidates for embolectomy. I think one of the things that one of the real critical insights about embolic material is that it's only available for 5 or 10% of the population. We do these embolectomies and sometimes you don't get anything back. But the insights that you get from this type of investigation can be applied to all patients experiencing acute ischemic stroke. And then to your second question, I think we are grappling with the large core trial results here at the University of Rochester. And initially there was a lot of reluctance, I think, to take on treating these patients who are going to have significant needs in terms of rehabilitation and potentially even assisted living long term. And there was, there were some questions about how the system would accommodate that. But one of the things that there was a nice editorial written by Josh Hirsch in the Journal of Neurointerventional Surgery that highlighted the fact that although there are more people who are dependent as a consequence of those procedures, more people who have an MRS of 4 or 5, you're taking those people from a higher level of dependency to a lower level of dependency. And so, even though we as neurosurgeons or neurointerventionists may be absorbing more of the burden because they're patients that we treated with surgery, in terms of following them longitudinally, that may be shifting from patients who are non-operative to patients who are operative, and therefore we're seeing them in our practice. Overall, I think it's pretty clear that there's a net benefit to them, and I think we've accepted that those are patients that we're going to be treating going forward.
Great. Are you recruiting other centers for this study?
No, we yeah, I mean, this is I have to say it's a little bit sort of fledgling work, but I hope to transition it that direction.
Wonderful. Thank you so much.
Dave, did you have a question, Dr. Miller?
Yeah, then Dr. Bender, Dave Miller. Yeah, I really enjoyed the talk. Really interesting work. I'm a little old school as well. I find it very interesting that you talk about adding TPA a little bit at the end of procedures and things. I often do as well. I like Dr. Talk, and even more so, unfortunately, I go way back to when we used to do TPA infusions for 20-30 minutes before the thrombectomy. And I have been relatively comfortable with giving a little of that. We also find, I think, and you may as well with the TNK, that maybe there's a little bit of add-on benefit to some of the distal clot because the TNK stays around a little longer. Obviously the potential, since the catheter's up there, and the potential for other substances, maybe some neuroprotective agents or other things to be injected. Your thought maybe on that? And then I also found it very interesting that you noticed the inflammatory component It is interesting. We don't talk about it very much. And this is all sort of after the fact stuff, but certainly you wonder, is there a role for something along those lines, either before somebody with patients with AFib, is there any role for something like that, identifying these patients and adding a protective component?
I mean, I think that sounds like you're more familiar with the literature than I am. And you know, when I came from Hopkins, I had never seen somebody administer TPA during an interventional procedure, and found my colleagues here, Tarun Bala and Tom Mattingly, doing it a lot of the time. So we've written about that a little bit. And I think probably 50%, if not more, of our embolectomies get TPA, either for adjunctively, you know, or as a salvage maneuver, or, you know, probably what we should be doing is what you alluded to at the end, which is giving it at the, you know, at the end of the procedure. I think there's been a bunch of recent publications that suggest that patients who get a little bit of TPA at the end of the procedure actually do better. And none of those are RCTs, but they're decent studies. So yeah, I think that's probably the natural first step, as I mentioned earlier, because of, you know, desire to sort of to limit toxicity. Yeah, I mean, I think making a transition to a clinical trial of some sort makes a lot of sense. I think the if you look it up there, and this is not literature that I'm super familiar with, but it's not like DNase is not being given to humans, you know, in other scenarios. It's used in a lot of pulmonary diseases. It's infused through chest tubes. It's given to patients
Correct. Yeah,
with fibrosis.
sure.
So the toxicity, the absence of toxicity should be fairly well established. And that should make it a little bit easier for us to transition, you know, into trialing it clinically, because you're over that hump.
No, I agree. I think you know, it's interesting that you and your colleagues have been doing it. Yeah, I was felt very, of course, urokinase even more so before TPA. Felt fairly comfortable with a lack of hemorrhagic transformation with the introduction of at least small doses of stuff. And so, yeah, I haven't hesitated too much to do it for cleaning up. It's interesting to find that you guys do as well. Well, listen, really excellent talk. It's one of the talks that have I think has helped me a little bit, because I know people have been collecting these specimens, and we have been collecting these specimens, and people have been doing a lot of looking, but I haven't had anyone I think doing the kind of, or I haven't seen the kind of work that you're doing. And I think it's really exciting stuff. I think some of it may be down the road more than right now, but that's where we need to be. Yeah.
I appreciate your engagement and your enthusiasm, Dave. Thank you.
No, thank you for the talk. Appreciate it.
Samir, did you have something, a comment, or Paula?
Yeah. Hi, I'm Samir. I'm one of the vascular fellows here. I was just curious, with your analysis of the data, did you find any correlation between imaging characteristics and the clot that made a particular type of approach more successful? Like, say, you would be more successful with XYZ findings with an aspiration only attempt versus with this finding, I'm definitely going to need to use a stent retriever in order to get this clot out. I don't know if you found anything like that.
I think that's another way to analyze the data. And we're sort of iterating all of these analysis in real time. One of the unfortunate limitations of the way that data gets produced by the way that data gets cleaned and produced by mass spec is that you can't really combine runs. So it's not apples to apples. So our first run was 24 specimens. We just got the results back from a second run of 59 specimens that should give us a lot more power to look at less prevalent things. And so, you know, we basically, honestly, the reason we started with atrial fibrillation was it was the best thing that split the population in two, that allowed us to sort of look at a variable. And, you know, aspiration versus stent retriever is another scenario that should split the population roughly in two. We haven't looked at that yet. Do have a publication out that's like literally out right now in JNIS looking at hyperdense cerebral arterial sign and the particular proteins that may represent. I think unfortunately it falls a little bit into the category of, this type of analysis can be done as opposed to something really actionable like this work, which is, still looking for a home. But hopefully we'll have one soon. So yeah, that's another analysis that's forthcoming. Thank you, Samir. Paula?
Yes, good morning. Thank you, Dr. Bender, for your talk. I wanted to follow up a little bit on with Dr. Miller's question. I wanted to ask if you saw any proteomic profile differences in patients receiving different types of medical therapy, for example, receiving TPA versus not, or other anticoagulant therapy or medical therapy, and if you're interested in looking into it with your new data.
We are, and we did not in the initial run of 24 cases. It's a little bit clouded by the fact that there's systemic TPA and then there's intra-arterial TPA. And so if you take 24 specimens and you divvy them up like that, it's hard to it's hard to get significant enough numbers to compare. But we'll iterate those analyses with the larger ends that we have coming up, and are very interested to see the results for sure.
Thank you, sir.
Well, I appreciate everybody's engagement with the talk. Thank you so much for.
Well, Matthew, no, thank you so much. This is really exciting, and again, for many of us who have witnessed this field evolving, this is becoming more individualized care, and this very encouraging, because I like what you said. Coming from Hopkins, you guys did not use IATPA, but many of the old guys, I wouldn't say old, let's say senior people who have been longer around. I mean, IATPA was one of the only tools that could be delivered, and many of those people contained, and I still use that. So I take, so to put things in perspective, if I can't put the aspiration catheter there, I don't use stent retrieval. I just push my aspiration catheter and then get it out. If I cannot push it there, then I need an anchoring thing. Then I put the stent in distally. It straighten my axis, and then I use the combination. First pass comes out, second pass comes out. After the second, if it doesn't pass out, my TPA is ready to go. And while deploying the stent retriever, I started from either the aspiration catheter before I start injecting, or from my microcatheter, which is immediately proximal to the clot. And I use big microcatheter to allow me to do those injections around it. And I don't know the success rate if you compare it, basically, but those are the techniques that many of us clinically we know they work. But it's very encouraging to see that the work in the lab is mirroring what we're seeing clinically. Like, what is it, a clot that would come out? And we know, we know sometimes after cardiac procedures, it's a piece of the cardiac valve that's stuck there, and how are you going to get it out? It's not all these clots are the same, and I don't think it's fair to deal with them the same pattern. So a great job. Again, I interviewed at Rochester. That was my first job, but I ended up here basically. Hi to Dr. Butcher and all the crew there. It's a great place. I think you're in a great place, and that we look forward to seeing your productivity academically. That's awesome.
Thank you so much. I'll say hi to Dr. Pilcher for you.
Thank you.
Thank you, Dr. Bender, for this morning. So you should have another link to join a few meetings with our residents and faculty, and we'll just hop in and out from there. So just stay there. We'll see you there.
Sounds good. Thank you so much. Bye, guys.